Stand by, everyone. I'm not seeing us stream yet. Okay. All right. Thank you, everyone, for joining us. I'm Kari Reagan. I'm the NATS chat moderator and organizer. And I appreciate you joining us tonight for this special edition NATS chat, Returning to Singing Post-COVID, What We Need to Know. For those of you who might be attending their first NATS chat, they are traditionally held the second Sunday of every month between October and May. And we cover all sorts of interesting topics for the voice profession, including singing technique, vocal health, voice pedagogy, business aspects of an independent studio teacher, aspects of being an academic teacher. So many topics, and you can find the archives of those chats for the last several years at nats.org or this channel, the YouTube official NATS channel. Recently, as many of you know, back in March when COVID first put us into lockdown, Alan Henderson, the executive director of NATS, and I leapt into action and held 8 special edition NATS chats to help our voice teachers remain online teaching. And we also had a couple that talked about the mental health concerns of both voice teachers and singers. And those are all archived and can be found. But recently I began to see posts on Facebook about concerns of they had a singer who has come back to voice lessons and was recovering from COVID and wanting to know what to anticipate and how to help. So I thought it was very poignant for us to start this conversation so that we arm ourselves with fact-based information. So to that end, I have a wonderful group of panelists. So I'm so grateful for the generosity of your time tonight. Let me just briefly introduce each of you. First is Dr. David Young, and he is a laryngologist formerly at Vanderbilt, but now at Emory Voice Clinic in Atlanta, Georgia. And he is also a singer. And for the record, neither Dr. Young nor myself have had COVID. Unfortunately, my other esteemed panelists have had COVID, and I'm so grateful that they're willing to share their experience tonight with us. First, I am so pleased to introduce Michael McElroy, who is the recipient of the 2019 Tony Honors for Excellence in Theater. He has appeared in numerous Broadway productions and was nominated for a Tony for Best Featured Actor in the musical Big River. He is the founder and director of Broadway Inspirational Voice, a diverse, non-denominational gospel choir made up of Broadway singers. And he also teaches at NYU Tisch School of Music. Thank you, Michael, for joining us. Also, we have with us Andrew Lee, who is a speech pathologist at the University of Washington-Otolaryngology Department, where I have the privilege of working with Andrew as a singing voice specialist. He is also an avid singer, and his parents are voice teachers. So he has, although he's chosen speech language pathology as his profession, he has an enormous background as a singer. And so his guidance will be invaluable tonight. We also have with us Cate Frazier-Neely, who is an independent studio teacher and a singing voice specialist. And she is also co-author of the book, Singing Through Change, Women's Voices in Midlife, Menopause, and Beyond. So let's begin tonight. Before we get into the conversation, I'd like to, Dr. Young has a wonderful PowerPoint presentation. So we're gonna kind of start with the big picture medical aspect and then wheedle our way down to the personal experience. So go ahead.
All right, so I'll go ahead and share my screen here.
Great.
All right, well, thank you for having me this evening, and we'll talk a little bit about the medical perspective on singing after COVID-19, and we'll see after I'm done with this how accurate I am as we hear from my other panelists. So I think for a lot of us right now, we really are not seeing that many singers who have had COVID coming through our clinics yet with symptoms related to COVID. I think in large part, this is because a lot of the theater and performing realm is shut down currently, so people don't have the same vocal demands that they would have had in a pre-COVID era. Certainly, we know that health insurance and finances and access to care were not easy for singers before the pandemic, and they've only gotten worse since then. And then there's the graph at the bottom that we've all come to know and love in many different iterations. This pandemic is affecting different places at different rates and in different ways. And so it's entirely possible that as this spreads throughout the world, that we will start to see more and more of this come through our clinics. So even though we don't see a lot of this yet, we can extrapolate based on other viruses and on what we know this virus does. So what do we expect to see? And I kind of divided this up into 4 major groups: lung damage, phonotraumatic lesions, post-viral neuropathy, both motor lesions, sensory, and then some of the airway concerns that may not be quite as relevant to voice teachers, but are really what we're mostly seeing right now in the clinic. I'll start off with the lung damage. And so this already, some of the papers have looked at some COVID patients immediately after discharge from the hospital, both mild cases and severe cases, and are noticing some objective data of lung function, but many of them do have some measurable lung damage. People I know that are runners that have had this have noticed their mile time is not even recovered, even though they had COVID back in March. And it's going to be some time before we see how long these effects last. Looking at things like SARS or MERS, both of which are caused by coronaviruses in years past, there were some papers out of those epidemics that showed that lung damage lasted a year or longer, or was even lifelong in some cases. So I started to think, like, what does this manifest as in the studio when somebody comes in with this? And I was thinking about all the some of the high altitude opera companies and whatnot, Santa Fe pictured here, or Central City or Aspen. Anybody that goes there, knows that first week or two as you're acclimating to the altitude, the sense of not having enough air, having to breathe between words and phrases you've never breathed between before. And I think that that's, in a mild sense, something you might see in the studio. People that are having some trouble supporting that didn't have it before, they have to take more breaths in between phrases. They may notice that they fatigue faster. They may notice loss of range. They may notice, their sound is a little breathier and weaker. Again, you'll kind of notice a lot of themes here as we go through all the different manifestations that the way they show up in the studio are going to probably be similar. The phonotraumatic lesions, probably from the prolonged cough, that's a real part of this illness. It can cause nodules and polyps and granulomas, and the common thing we see in the voice clinic. And I would not be surprised to start seeing more of this from COVID. And these two can vary widely in how they would present it, depending on what the lesion is, where it is, what kind of music the singer sings, what kind of mode of phonation that they're working in. It could be as simple as you don't hear anything, but they feel something is wrong, all the way that you're hearing breathiness and they're fatiguing early, they lose range, have issues in the passaggio that they didn't have before. You start to notice, a technically adept singer that usually can make corrections very easily is suddenly finding they can't do what you're asking them to do. All things that should raise your eyebrows a little bit to start thinking, is there something else going on? Certainly, viruses have a long history of attacking nerves. We've all heard about the loss of smell and taste. It's now a symptom commonly associated with the early stages of COVID-19. That's, of course, because the virus attacks the olfactory nerves, but we've seen viruses for years attack the laryngeal nerves, both the motor nerves and the sensory nerves. So, certainly with the motor nerve being attacked, you see the picture on the top right of a kind of a classic left-sided vocal fold paralysis. And that's going to manifest with, a lot of breathiness, a lot of early fatigue, changes in the speaking voice pitch. If it's just a weakness of the cord, they may actually have a fairly normal speaking voice because they can compensate, but they're going to notice when they're singing something's not right. The passaggio is more challenging. They lose their upper range. They fatigue earlier. As far as sensory manifestations, we see a lot of chronic cough caused by that, chronic throat clearing. The singer that's doing that more often than they usually would, maybe singing or talking, suddenly triggers them to have a coughing fit. All things that make you start to think maybe there's some kind of a sensory neuropathy at play. And finally, the airway issues. This is kind of one of my passions clinically, and certainly something that we're sadly seeing more and more of because the intubation and prolonged mechanical ventilation that's part of this disease process. We know this results in airway injury, and certainly things like how long the tube is in and how big the tube is. we already know from our literature leads to more likely having an injury. And this disease, people are being intubated for 2, 3, 4 weeks at a time before then they ultimately come out and get a tracheostomy that itself can often have some tracheal stenosis issues afterwards. So I think these are not going to show up in your studio. These are going to be people that are going to be plugged into care. They're going to have trachs. They're going to be struggling to breathe. They're going to have a lot of other problems. And be aware of it. There's something seems wrong, certainly get them plugged into care. But this is something I think for the time being, you're going to see probably more in the medical world than you're going to see. Kind of just some quick kind of thoughts. What can teachers of singing do? I think first of all, the fact anybody watching this and starting to try to get familiar with what this virus will do to singers, just being aware of what it can do. You probably heard me repeat myself a lot with the symptoms, and there's a reason for that, because with phonotraumatic lesions or neuropathies or lung problems have a lot of similar vocal manifestations. And so that's why early referral to a medical professional is really critical. I mean, I would never be comfortable diagnosing somebody with something based off a Facebook post or just listening to them from a distance. I might have 19 or 20 different things in my head I think it could be, but there's a reason in the clinic we look. So getting somebody plugged into professionals that can actually look at the glottis and get some pictures and see it in motion and has the right equipment to make a diagnosis is absolutely critical. Also point out there's limitations to technical solutions. There's, despite many online senior teacher gurus that try to say that their particular technique has fixed this or that laryngeal problem, and some laryngologists told them their technique was a miracle. That's not really reality. And so, when people have actual medical problems with actual lesions of their larynx, you're going to find that the technical solutions aren't going to work. I think it's important not to blame yourself, not to blame the singer, but to think that there's something else going on that maybe needs the help of a different profession. Once those things have been diagnosed, I want to say what you can, singing is healing. We know in certain disease processes, whether it's preventing vocal fold atrophy with age, addressing people with Parkinson's disease, and just recovering from singing, lung damage and things like that. The singing and breathing is a healing thing. So once you have a singer and you know that you've eliminated the fact that there's no other lesion going on that needs medical attention, the singing itself is such an important part of healing. So whenever discount your role as a singing teacher and as a singer and healing your students and yourself and your community. And then finally, my last plug, prevention, of course, is the best medicine. I'm a big fan of masking. I think they're wonderful, but there is no mask that can do what distance does. So don't forget that as we're all trying to plan how we sort of go back in and do we teach in person, do we integrate with the world, but always remember that prevention is absolutely the best way to manage the sequela of this. My little brief spiel, I will turn things back over. I will unshare my screen. Back over to Dr. Young.
That was wonderful. Thank you so much, Dr. Young. And we'll cover some of this a bit more as the conversation goes, I'm sure, but I always say that if you hear a change in the voice for 2 weeks, that is when you refer. Is there anything different about if somebody has had COVID? Do you think they should automatically have a baseline scope, or only if they present at a particular time with a certain symptoms? Do you have any thoughts on that?
I think your standard and wisdom there is pretty good. I mean, if this is something that lingers, for 2 or 3 weeks and it's not going away, it's not responding to solutions that would have worked in the past, I think that's the time to start thinking about it. I know that understandably, especially in the United States, access to care is hard, care is expensive. Getting seen by an otolaryngologist and getting a strobe is not inexpensive. And so I think, we have to be judicious with people's resources and time, and I think giving it a reasonable trial period to see, is this something transient that goes away, it wasn't an issue, versus something that persists. I mean, every singer's had trouble with the passaggio one time or another.
Right.
They have a lesion, but if it persists and is not reacting and they've had something like COVID or another disease, again, give it a reasonable try, and then it's time to get a medical opinion.
One more question before I then move to my other guests and get their story a bit. We have a question of, we are hearing that asymptomatic COVID patients are also having post-COVID effects. Are these types of patients exhibiting many of the same effects that those who have had a more presenting case, or can those who are asymptomatic able to assume their post-COVID life will be easier?
That's a good question. I don't really know of actual data that's looked at this yet. I mean, certainly I think it makes some common sense. Some of the other things, certain things like lung damage and whatnot may be a little harder to tease out. And I think it's going to take some time. You certainly may have some lung damage, but if you're not a physically active person, you may not realize you have. We have a lot of patients that have airway lesions and lung damage for other reasons that don't really notice it because they're not that active. And then you have younger, very active people that have much more open airways and much better lungs that are really debilitated by the limitations of that. So that's a hard one to answer. I don't think I can really give a definitive answer.
Thank you. Well, let's bring our other panelists in and let's go back to the personal aspect of this story. I actually personally don't know anyone who's had COVID that I've really sat down and spoken with. So I'm eager to hear a little bit about your stories. Will just if you could share a bit about your symptoms and where you are in your recovery, and then a little bit later in the chat, we'll get into more specificity with regards to singing. Michael, would you like to lead us off?
Sure. As you said, I teach at NYU, and in March, we were told that we were going to be shutting down and going remote, I think about the 10th or the 12th of March. And we finished on that Friday, and the next week I just started to feel like I was just getting a cold, like a sinus infection, those kinds of symptoms. And by Thursday night, it like out of nowhere, it was a wave of sweats and shaking and severe headaches and very difficult to sleep. Called my doctor, and talking through the symptoms, she said there was probably COVID, but at that time, they weren't seeing anyone at the hospitals. They were saying to stay home. And because a lot of my friends are in the theater, it was happening all around me everywhere. My roommate also was sick, and then I was sick a few days later, and very interestingly, with some similar symptoms, but very different symptoms. We both lost taste and smell, but I had more of the severe exhaustion, severe headaches, sweats. And then after 4 weeks, it took about 4 weeks to recover. And then right at the end of the 4 weeks, I ended up with that cough, and the cough came, and for 4 weeks, I could not stop coughing. So it was a strange kind of, once it was at the tail end, a whole new set of symptoms came. And then a month later, I had the antibodies test, and I did in fact have the antibodies, and have had another test since, and I'm still don't have COVID, but it's been tricky because every time there's any kind of symptom now, you think, is it this? But I've been healthy and working from home. So it was a very challenging time for our community here, for a lot of actors. A lot of friends ended up in the hospitals, and a lot of loss of life here in New York City. And we have finally seen that curve kind of going down. So it was a pretty scary time.
Thank you, Michael. Are you now, would you consider yourself symptom-free?
I would. A couple of weeks ago, I thought that because I am prone to sinus infections and things like that, which strangely enough, since we've been in quarantine, I haven't had one sinus infection. I thought I was getting sick, and it felt similar to COVID. So that's why I went and got a test, and it was negative. So I've been pretty much okay. Building up strength, which we'll talk about later, to singing again was a whole other story.
Okay, and that's what we'll be eager to that. Andrew, how about, was your experience anything like Michael's or completely different?
So I've actually heard, I've known a couple people now who've gotten the virus, and so it's always interesting hearing the slight variations in how our symptoms presented. So similarly, back in March, actually the first symptom that I experienced was the loss of smell and taste, and that was actually before anyone thought anything of it. I went to an urgent care, and they actually didn't think that it had anything to do with the virus at that point. But then the next day I started to develop a really bad cough, and that was, I think, the first symptom that kind of raised hairs, and that's what triggered my physician to order the COVID test. And then it came back positive. And actually, I was pretty down for the count for 6 good weeks, where I just also could not stop coughing, extreme fatigue, and I was probably sleeping for about 18 hours a day, where I would walk to the bathroom and back, and it would feel like I ran a marathon. And I had that shortness of breath, treated with a lot of albuterol and some teslamprol, some neuromodulators, just to kind of suppress the cough a little so that I wasn't so uncomfortable. I actually really didn't get, I had a fever for about 2 days, around week 4 of 6. But then really right around 6 weeks is when the cough started to subside, and I felt like I had a little bit more energy. And then since then, I've also gotten a negative test and antibodies.
Okay.
Mm-hmm.
And so do you feel predominantly on the other side of?
I would say predominantly on the other side. I think I'm acutely aware of my function. I do feel this tickle in my throat, that kind of chronic cough sensation. I'm working really hard, we treat a lot of chronic cough, just speech pathology in general does. And so really trying hard to suppress it with some of the techniques that we're trained to train other people. But yeah, I would say overall function-wise, energy-wise, I'm feeling pretty back to baseline.
And were there medications that you took to suppress the cough?
So like I said, the only one that I was really prescribed was teslamprol. So neuromodulators, it's just, I could name a few. I named a few off to my physician. They're like, why don't you try this one?
Okay.
Sure. I don't know that it helped a whole bunch, but at the very least, it was psychosomatic, made me feel like I was doing something for it.
Yeah. Thank you, Andrew.
Mm-hmm.
And Kate, we already have heard, Michael didn't have a cough show up for 4 weeks, and that was one of the first presentations for Andrew. How about you? Where did you begin?
In March of this year, I was in and out of a rehab unit a lot to help monitor my 84-year-old mother who had had major hip revision of a hip revision. And she was discharged to us, to my husband and I, because she needed a great deal of care in addition to physical therapy and that. And about a week after she got here, I started running a 101-degree temperature, which is high for me, and it felt dreadful. I did not develop a cough, ever, thank goodness. I developed massive migraines and headaches. I was interested to hear that Michael had experienced that. I don't get migraines. It's one thing I do not get. And had to call my doctor. We talked things through. At first, she was very concerned because the whole left side of my face had drooped. She thought I had had a stroke. But I think this is where the neurological dysfunction comes in. But the more she talked with me, and this doctor knows me pretty well, the more she decided we would just wait. And about 3 or 4 days later, the face became a little bit more asymmetrical, or symmetrical is the word I want. I did have trouble sleeping at night, and I was quarantined for about 2 weeks. Now, my husband and my mother were here. Throughout this whole thing, it is a major miracle that neither one of them got it. But after 2 weeks of caring for me and my mother and working full time, my husband was toast. So after that 2 weeks, when my temperature went back to normal, then I was allowed back downstairs, and there followed this 2.5 month period where I was barely conscious of how I was feeling because my mother needed so much care and I was still trying to teach. After she left, I had an entirely different set of symptoms. And this is what I'm in the middle of right now, although it's getting better. Muscle weakness and imbalance, lung heaviness, the stamina is like Dr. Young said, if you're inactive, you might not notice. But we're in a profession, whether you're on the performing or the teaching or both, that requires a tremendous amount of energy. And I know when I can't function like I'd like to. This is a symptom that is hard to describe. If I'm trying to concentrate on something and I have to watch it during this session, it's like my brain heats up and swells and then starts pushing on my skull. And it reminds me of when an appliance or a computer is heating up and is about to short circuit or go on the fritz. I don't know medically what that is, but that's what it feels like. And then I have to put a cool washcloth over my face and rest. I have to try to catch it before that happens. So if I end up on the floor, you'll know what happened. that is happening.
Hope not.
The other symptom is that I no longer have was I did have a little trouble swallowing. Because of my own experience as a bilateral paresis patient and someone who's overcome that, I automatically started doing the things that I did to help that, and that went away within a few weeks. The main thing right now is the stamina, the brain heating up, and breathlessness when I try to sing.
And you're still in the middle of experience, and you're at 5 months now, about, correct?
Yeah, now I don't know if the length of this has to do with being older. I don't know. I'm in better shape than a lot of people who are 20 years younger. So who knows? All I know is that it's been ongoing and surprising, because you might be very ill during the initial weeks and then think you're doing better, and then a whole new set of stuff starts showing up. So that's my experience.
So before we talk about the singing part, Dr. Young, any observations or comments just from hearing each of their stories or thoughts that you want to share with us from your medical perspective?
Yeah, no, I mean, I think it's just interesting how viruses do. They kind of, they take a similar path, even though some of the symptoms and the timing can kind of see how the virus progressed and unraveled in each person in kind of a different way. Whether it was with, vagal sensory neuropathies with Andrew, or then, with Cate. I mean, you hear kind of what sounds sort of like there's another disease where herpes virus can actually, I heard this says, herpes zoster, the shingles virus can attack the facial nerve, and you get facial droop, and you get balance things, you get headaches, you get difficulty focusing on things. And so again, you still see that kind of same, viral neuropathy picture, just in her case with the 7th cranial nerve instead of the 10th cranial nerve like you'd see in the larynx. It's fascinating, kind of the similarities in how this virus behaves.
Could I ask you, Dr. Young, about vetted information on how Epstein-Barr might be related to COVID-19? Have you read anything, or am I making stuff up?
I have to look. I mean, I haven't heard anything like that. I mean, I think of them as rather different viruses, but again, I think, the way that viruses, the way that they interact with our immune system and our bodies, there's a lot of similarities, and certainly, Epstein, EBV or, zoster, or coronavirus, they can, when they get into the body and they get into nerves and they attack these different tissues, they do a lot of similar things, even if they don't have a particular structural or genetic relationship among themselves.
Thank you for that. So Michael, tell us, obviously, of course, performances are by and large shut down, but have you begun to sing again and vocalize, and tell us a little bit about that?
I did. Being in quarantine, there were a lot of performances and concerts and things that all of a sudden had to go virtual. And I was asked to do a lot of performing. As I think my voice teacher, since I've been in New York since the early 1990s, is Joan Lader. So a lot of the training that I've done with her really has saved me, not only to do 8 shows a week, but in this moment, because there's this thing to try to go back to what you could do before, and the body, the voice, it's just not ready. So things that didn't usually bother me or were easy to do, now all of a sudden I found myself fatigued quicker and weaker. And it took me a while of using the technique that I'd learned with Joan so that I wouldn't push and hurt myself, and to continue to kind of build up my strength again. The biggest difference for me is that, you know, I'm a pretty active person, and most of my life is spent sitting in this space on Zoom. And so I'm a person that likes to go to the gym every day and work out and do, you know, cardio. So I honestly couldn't tell you how my breathing is, because I haven't had to do anything of that extreme, right? So we'll see if gyms ever open up again, if there are any long-term breathing issues. But it did take me a while to build up my strength again, to sing and not try to push myself back where I was.
And do you feel mostly back into full voice?
Yes, actually, yeah. It's been it's much better, much better.
So you mentioned about some breathing exercises that were given to you. Is that right? I see in the question box, and were there some specific breathing exercises recommended?
No, I think someone was asking, but no.
Okay.
Just followed all of my Joan later techniques.
Okay. All right. And Dr. Young, there have been a few articles about chronic fatigue syndrome, but are there any vetted resources with relationship to COVID that you know of?
Yet, you know, I think we have to kind of remember, you know, typically the kind of chronic fatigue thing we see kind of follow other viral infections, and tends to be kind of a longer term sequela of these infections. You know, even though it feels like we've been living with COVID for 5 to 10 years, it's been about 6 months. And so we're still in the very early phases. So I think that we'll see some more data come out over time, but I don't know of anything really definitive peer-reviewed just yet.
Is there anything about the fatigue that we're hearing about tonight, and that we've heard from other singers, that is specific to COVID, that we, as either in the clinic or as an SBS or as a voice teacher, should be attuned to? Is there anything specific about how to help resolve it that's different, the voice fatigue related to COVID?
Well, that's a very broad question. I think it really is going to depend on what the exact etiology of the fatigue is.
Okay.
So if it is a vocal fold paresis or phonotraumatic lesion or loss of pulmonary function, it's going to be very different than sort of your a more vague whole body systemic chronic fatigue, you know, like you sometimes see like after Lyme disease and things like that. You know, one of these other kind of infections, those kind of a little bit different. But I think it really depends on what is causing it, and I think kind of harkens back to the importance that if somebody's having symptoms, that they get a good medical evaluation to make sure that we understand what's going on, or at least what's not going on.
Mm-hmm. There was an article, voice therapy in the context of COVID, clinical practice guidelines. And I thought this was interesting. Essentially it says that vocal fold epithelium in subjects with COVID was found to present a high expression of angiotensin converting enzyme 2. This data could explain the etiology of vocal fold edema of dysphonia related COVID. I was just curious if you had.
That's a bit of a stretch. And so this is sometimes where the intersection of basic science research and clinical reality can be a little bit tenuous. I mean, you know, is dysphonia after COVID because 3 or 4 weeks of constant coughing, or is it because there was some higher viral expression there because there were angiotensin converting enzyme receptors there, you know, teasing that out? I think that's kind of hard to say. Personally, I think I would put my money on the prolonged coughing and other kinds of things causing that, rather than the kind of a differential expression of receptors.
And that is why it's so important to have someone like you on it, because again, and this is a vetted article, right? And so somebody might misconstrue that information. So that's very interesting. I really appreciate that perspective.
Yeah, I think if you get these clinical practice guidelines, you know, it's not so much a peer-reviewed study as it is a review of the current literature. And some of that is, you know, what that citation is kind of what I call a hypothesis generating one. So it's certainly an interesting question to try to go back and look at and say, is there some correlation with these, expression of such and such a receptor and this particular symptom? But that's not really proving any kind of causation. And you're right, that can be, especially for people that aren't used to reading the scientific literature in depth, it can be a little bit tricky to tell the difference.
Yeah, I appreciate that. It's always good perspective for us to keep in mind. So Andrew, quite a few questions for you, but just can you tell me when you started to sing again and a little bit about that trajectory?
So I don't know if the others also experienced this, but I had a lot of dyspnea just even at rest. So, shortness of breath, even just at rest. I would be lying still and would feel pretty like heavy weight on my chest. I would say as I start to sing, the biggest limiting factor was feeling like I couldn't get enough air. But then also the cough being concomitant to that, in that phonation would trigger a cough, which again kind of looped me back into, my profession of, okay, this could be the virus, or it could be sort of this post-viral neuropathy, this cough syndrome, if you will. So again, I kind of worked through the exercise to try and mitigate any sort of habitual component of that chronic cough. I think so I know Michael was mentioning he wasn't really physically exerting himself, so it was hard to know where his lung function really was. I had the luxury of just kind of being in a fairly secluded area where I could go for runs, and I felt quite limited. And so as soon as I started feeling like that was getting back is when I started getting back into singing. When I was finally able to suppress the cough, I found that I was having to really, exactly like what Michael said, work through technique, in that there were ways that my body wanted to compensate to make up for some of the ground that I had probably lost, deconditioning, all of this. And so it was kind of just working through what I knew from vocal function to get back into that. And I would say that now I'm quite close to where I was. There are a few things that I still notice I'm very consciously having to work through to make sure that I don't slip back into compensation. Like I was mentioning, kind of one of the lingering symptoms I have is sort of this residual sensation of that need to cough. And I'll notice that I start to hold to suppress that cough instead of singing through it, allowing breath through. So it's a few of those things.
Mm-hmm. Mm-hmm. So you've mentioned a couple times some techniques for suppressing cough. Mm-hmm. Can you share a couple of those with us?
So there's one kind of cornerstone technique. It's called quick release breathing or open throat breathing technique. Essentially, I kind of use it with patients who have this habitualized component of their cough. Essentially, you've got this stimulus, which is I have this need to cough and an associated behavior. I then cough, which every time that you respond with a cough in response to this sensation, it just reinforces that behavior. And so instead what you start doing, the technique in itself is pretty simple, but it has to be done really specifically, where it's prolonged exhale through some sort of semi-occlusion. Typically I like to do pursed lip exhale through the mouth, followed by a steady inhale through the nose. The exhale through the mouth is actually twice as long as the inhale through the nose, essentially, because that's when you get the back pressure effect, which kind of mitigates that need to kind of clench and squeeze the throat there. So just doing that in a cyclical manner without holding the breath ever.
Okay.
Mm-hmm.
Thank you for that. So Cate, tell us a bit about your journey back towards singing.
I can't say that I lost any singing function, but I did, having lost lung and lung capacity and basic stamina. Yeah, okay, whatever. Yeah. but because I have this lifetime of working with somatic education and vocal pedagogy and somatic perception, there are about 4 or 5 things I did to start again. The first was get a pulse oximeter if you need one, because it measures oxygen in the bloodstream. And when I was kind of trying to decide what to do, I started with that to really get a feel for, to start to match up how I was feeling with what was actually happening in my lungs. And if I will say that if I stop noticing improvement, I have no hesitation to go see a pulmonary specialist. But so far what I've done is I see my Bowen, B-O-W-E-N, body worker, who does a form of fascia release and follows a different meridian system than Western medicine does. I find a great deal of shifts in how my body feels afterwards. And I also I practice some Qigong moves for lung health. And there's a video up, it's called Qigong for Lung Health by K-S-E-N-Y. And my brother-in-law is also a Qigong teacher, and he's helped me a great deal. And I've been a practitioner of yoga since 1985, but let me tell you, I wasn't able to do much at all. And so what I decided to do was start with chair yoga for the geriatric community. And I found some videos and I started doing them. I remember the first time I did one, this might have been about 2 months ago or a month and a half ago. I really, after 1 minute, I had to take a nap. And that increased rapidly the more I did it. Now I'm at the point where I can actually practice yoga again, but I've got a ways to go. And this breath that Andrew talked about is similar to many things in yogic traditions where you practice different kinds of breathing. And when I got to the point where I felt there was more elasticity, and I don't know if you want to talk about this now, but I'll throw it in. I ended up using a variation of the lip trill, which, now get this, I've never used before. In 42 years, I was certainly aware of it, but I never was helped by it before, and I found that it didn't really help my students. And so I did other SOVTs. But I want to show you what I did. When I first started, I had to start, and this is kind of an overview of what you can do with your students too if they have COVID. You start in small, manageable chunks, and you have to use some imagination to take an exercise and truncate it to what the singer can do, which is what good pedagogy and body work and breath work does anyway. And I would start with raspberries, just going, and then I would use my abdominals to push my chest up. This isn't how you sing, right? It was just an effort to prime the pump. And the first couple of times I did that, I went and took a nap. And then I went, I was just making noise. And after a couple of days, I could do the third, and then the fifth, and then the octave, and then the 10th. And it took 3 weeks of working a few minutes every day to do that. I'm also, my mentors are Elizabeth Daniels and Jeannie Levetri, and like using Joan Lader's techniques, I used their techniques, and eventually found on YouTube, there's a show with Ellen DeGeneres talking to Celine Dion, and she does this version of the lip trill, which combines a little bit of artistry and messa di voce. So I'll try to do it now. that one I can only do about 3 or 4 in a row. I've already broken out in a sweat from that one thing. And it's very, very gradual. You as a teacher have to pull things as far back as you can, and pacing and rest and noticing what that person is doing. You know, it's not just high functional listening, it's perception. Will help you in a shortened lesson. That's the other thing. Use a shortened lesson. And I know your income might take a hit, but we're here to serve people. So those are some examples of how I have started to sing again. Laryngally, vocally, from the source, there were no problems. All the problems came from those other things.
Well, you know, to your point about we're here to serve our students, you know, perhaps that instead of an hour lesson, they do 2 half hours or 4 15 minutes if that's what's needed. I mean, there would, you know, be a way that would benefit the singer to have a little bit more supervision. I'm actually very encouraged that all of you feel essentially back to your pre-COVID singing voice. And I think that's encouraging, and that you all had specific approaches that helped lead you back to that. And I would say it would require a teacher too that has some experience. I would say if you're a younger teacher or starting out and somebody comes to you like this, you perhaps would want to get a mentor to help guide that process. And Cate, I just have to say, I saw your Celine Dion post that, and I've been using that for 2 weeks, that little exercise. Oh my gosh, I just love that. And I think to give full credit, I think it was her teacher, Seth Riggs. I always like to credit when there's a creative new exercise that comes into my life. I always try and credit the author of that. So I want to give credit to, I believe she said that was him, but that is a wonderful little exercise. Yeah, I was so grateful for your post on that. So let's talk about in clinic and in voice studio. Now that you guys have experienced this, how is that? Have you then, Michael, have you had students that have come to you that are recovering, and share a little of that experience?
Well, my work centers more in vocal performance, but we have been on break. I have been teaching. I taught some master classes with Australian students in Australia, but at that time they had not had the outbreak because they shut down pretty quickly. And since that time, they have had the outbreak in Melbourne, where I was teaching. And I teach now on, you know, high school students who are preparing for this new wave of how they're going to be auditioning for colleges. But none of my students have I had since we shut down, well, since we finished classes in May. And it was interesting enough, I didn't even mention that I missed one day, and then I worked through the 4 weeks of COVID,
Wow.
which was,
Wow.
like Andrew said, it's like you were fine 1 second, it literally felt like someone pulled the plug, and it was just like my body would literally go down, and I couldn't move. But I could drag myself into the shower, sit here at this table, and teach my classes for 6 hours a day. So I will be seeing all those students again in a little less than 2 weeks. And for the most part, I haven't heard from many of my students. I teach a lot of students who actually had it, only a few.
Okay.
More of my choir members,
Yes.
more actors. I know that I had 3 friends who were hospitalized and who made full recoveries, but we'll see what happens in the fall. We're going back into this fall semester remotely. Our NYU's Dr. Fauci, I call him, has said pretty much that there can be no singing in classrooms at all, which I was happy to hear about, because there's just no way to do it in effective ways. How many people in a room, in a face guard, in a mask? It's just, it's not possible. So we will be remote through the first semester, and then we will see where the cases are in the spring and start there. But I haven't had the students who've had it, so we will see what happens when I come back in the fall.
Are there a couple exercises that, like Cate shared, a couple that seem to be her go-to to help her establish baseline again? Do you have one or two
yeah.
to share?
I got this from Joan. It's the one with the straw. The straw is where I start. I always start with the straw and blowing air through the straw and going up in fits. That always works for me. And then I go to the lip trills and I'll do the lip trill, then I'll do the tongue trills. I always start easy, and it's exactly what Andrew was saying is that you have this idea of what you can do, but you can't do it. So your body starts to compensate in strange ways that you haven't done in a long time. And so it really took a mindful kind of approach to my technique, but also starting slowly, starting a little bit at a time, starting with the easy things like the straw and the lip trills to just see where I was and to slowly work into it that way instead of trying to remember what I used to do and how I used to sound and trying to recreate that sound in a way that wasn't healthy.
Thank you. That was such great advice. I work as an SVS, so I work with a lot of injured singers and have for over 20 years. And it's such a slow pacing. And I'm used to that. It doesn't, I enjoy it actually. And sometimes we work from what we call best voice. We have to find one single note in their range that is their best voice and grow from that and build from that. So everything you guys are saying just goes along with any kind of vocal injury or pathology that we generally are trying to help people recover from. But very slow and lots of questions, asking your singers lots of questions and feedback for them to guide the pacing and the direction. Andrew, how about you? What in clinic and what thoughts? In fact, have you worked with any clients?
So, not singers in particular, but
Okay.
definitely a lot. I feel like we're kind of seeing that first influx that from that first wave of people who got it, who are now dealing with some of the sequela of recovery. Lots of airway issues, lots of chronic cough, some just general voice changes.
Mm-hmm.
What I will say though is that in terms of clinical presentation, while this is a novel virus, I will say the problems that people are coming in with are not new problems, right? These phonotraumatic lesions, it's not a new kind of lesion that we're seeing. It's just a new source for these lesions that, kind of created this scenario in which they came about. I keep touching on, so does Michael, these ways that people are compensating for some of these deficits are not new problems. And so I'm finding that it hasn't changed our clinical approach for treatment.
Mm-hmm.
So in that same regard, voice therapy is still voice therapy. We're not talking about speaking voice, performing voice, singing voice. We're talking about vocal function, trying to figure out what is the optimal way. Let's say you've got new anatomy, you've got a new limitation. Let's talk about optimizing use patterns of what you've got, knowing that this could be what you have long term, it might not be.
Andrew and Dr. Young, can you talk specifically about breathing as a result? Because I have to say that's not a common issue when somebody comes in with a lesion of some sort, right? But this virus directly is impacting respiratory function. So what advice would you have for a singing teacher? Their student comes in and they're noticing limitations or leading to a cough or something. Thoughts on that from either of you?
I'll give this one to Andrew, actually. This is probably a little more what he deals with people that have poor respiratory function or not enough respiratory drive and energy. So you can probably speak to kind of the clinical side of this better than I can.
Yeah, I've got some thoughts on this in that, we see people with, chronic obstructive pulmonary disease, and just reduced lung capacity in general. However, when I think about vocal function, in order to, facilitate one oscillation of the vocal folds, it's 3 to 5 centimeters of water pressure. It's not much pressure required to generate a voice or phonation. And so, that's not to downplay that lung damage and reduced vital capacity is probably going to impact maybe how long you can hold a sound for. But I kind of think of, where are the specific limitations? Are people saying, I sound exactly the way I want to, the effort level is the same, I just can't hold it out for very long, that's not a complaint that I really hear a lot of. It's mostly, it takes a lot of effort in order for me to get to this one place. I don't know how much of that is directly related to I've got reduced lung function, right? I kind of think of even, oh, these notes are higher and so forth. You know, people talk about breath support. Oh, it takes more breath support to hit these higher notes and whatnot. And to me, my idea of breath support is just maintaining the same amount of pressure, subglottic pressure, regardless of the pitch. So in my mind, it's, okay, let's talk about, you might have reduced lung function. So how are you, say, using that reserve across a phrase or across what you need to get done, and making sure that you're not compensating in the wrong ways.
So to your point a few minutes ago, it's that, again, there's nothing new specific to this virus. So whatever you would be doing with the singer to help mitigate compensatory behaviors with breath management, that's what we apply here. If they need to shorten a phrase, if they need to sing, modify the tessitura for a period of time as they recover, so they don't develop compensatory behaviors.
Right. I like to think that it needs to be really specific to what the limitations are. You know, to say, oh, I've got reduced lung function, now my singing doesn't sound as good. Right? Is that really related to lung function directly, or is that related to maybe how your laryngeal posturing is differently is compensating in a different way?
Fantastic.
Comment about the lung function. The one thing I think where it kind of manifests, this is why I put that in high altitude thing in my initial talk. So when people go to sing at high altitude, and obviously the partial pressure of oxygen at altitude is a little lower, the actual amount of gas in their lung, the pressure they're generating, shouldn't really be much different. But the brain, sensing that lack of oxygen in the blood, that sensation, that proprioceptive feeling that I must take a breath. I mean, the first time I ever did a gig at high altitude, in La Calumnia, having to breathe between La and Calumnia, because you just suddenly, even though the air was there, you suddenly couldn't. You felt like you had to take a breath. So I think there may be certainly some sensation issues if somebody's lungs are not quite optimal, even if they're generating pressure, they may feel like it.
And to that point, like I said, exactly, it's it's hard to, I think this narrative can also be misconstrued to say, oh, this issue is in your brain, but I actually think the solution is in your brain. Like I said, it's just your body's natural way of compensating in response to some of these deficits. And I think the retraining, the recovery comes from, here's this stimulus, again, that need to take another breath, that breathlessness that makes me want to compensate. And then retraining it with, no, this is the technique that I'm going to go with instead.
And Cate, how about you? Have you worked with any singers recovering?
Well, I have worked with two, or I work with two. I work predominantly with professional singers in Americana and jazz and blues, some classical, which is my background. I lost all my classical students after my paresis was diagnosed, unfortunately, and musical theater. And the biggest thing, and perhaps one of you can explain this perception of not having enough breath. It seems to take, for these two particular people, it seems to take the form of the rebound, the elasticity of inhaling in an easy way. Just doesn't happen. It's not so much feeling like you can't get enough breath as the rebound doesn't happen. So you will sing and then you won't be able to, I don't like the words take a breath, rebound into the next breath. That's a very natural occurrence at the end of the phrase. That's the part that, and then you get tighter and tighter, that you often have to kind of work in ways that are not typical pedagogy or vocal function ways to get at. And I was wondering if anybody had any comments on that, because I find that I need to fall back on, for example, one of them had a lot of coughing, the other one didn't. The one who had coughed a lot, the muscles of her torso were in hyperfunction. You know, they were, my colleague Linda Valero calls it overdeveloped, but I would call it hyperfunction. And in that state, they stay like this, and it takes a lot of energy to relax. But people might not realize that it takes a lot of energy to relax. So if your muscles are in a state of hyperfunction, getting them to relax first before you can start this ebb and flow again is actually quite crucial.
Andrew or Dr. Young, did you want to?
I've got some. Go ahead.
And I was going to say, I mean, again, kind of what you're talking about, some of the literature is showing some of the pulmonary function testing coming out of people who have been hospitalized for COVID. There's certainly, you know, we classify pulmonary diseases as obstructive versus restrictive diseases. You know, so some of what you're describing, you know, could really be consistent with a restrictive lung disease. You know, things just aren't able to expand as much, that you have decreased lung capacity as well as ability of oxygen to diffuse across the lung membrane. I mean, that could certainly be something we'd see, and there's certainly some objective data out there in the literature now that we're seeing some of that in certain circumstances. I mean, I think that's
So we're just having a little trouble understanding you, Dr. Young. I'm so sorry. I heard most of that, just that last little bit.
I get closer to the mic because I didn't get any of it.
Do you mind repeating a bit of that, Dr. Young?
sure. It's better if I'm kind of right here.
It is. Thank you so much.
Right. So, I mean, we often classify pulmonary diseases into different categories, and some of the bigger overarching ones are obstructive, such as COPD, asthma, versus, you know, restrictive diseases where you see you know, pulmonary fibrosis or, you know, obesity-related hypoventilation syndromes and things where you just cannot expand, cannot fill the lungs, where you have that decreased capacity. So there's been some evidence that people that have had COVID, some of their pulmonary function testing do sometimes have a restrictive pattern, you know, that would kind of fit with that, which I think fits exactly with what Cate's seeing with some of the singers, where it's, whether it's from a hypertonicity of the intercostal musculature, or if it's just from, you know, fibrosis and damage to the interstitial tissue of the lungs themselves. And it's hard to say. I don't know if there's data on that yet, but I think everything you're saying fits with what we're seeing more broadly with this and other similar.
And Andrew, it sounded like you also had a response a bit.
So, of course, you know, there could be structural physical restrictions in terms of that breathful, but from what I'm hearing, it sounds like, as you're saying, hyperfunction to me, you know, that I am kind of taking that as she has the ability to, but her body is not really allowing her to at this point because it's compensated because of this chronic cough in which you are engaging all of those muscles. I think it's almost impossible to have someone relax actively because you are actively having them do something passive.
I think somatic education can take care of that, though, because there are ways to go about building in awareness. I mean, building in awareness is almost, as you would know, is almost the first step. And so when you're working with someone who is restricted, I mean, there are a million different reasons why they could be restricted like that, but to have a healthy professional singer go from no issues to this.
Yeah. So my approach in doing it, especially hyperfunction, is probably the number one thing that we treat. You know, I like to give permission to these people to say, hey, you're not doing this on purpose. It's really hard to relax things on purpose. So instead, what I have them focus on is doing some, you know, physiologic activity that is completely incompatible with muscle tension or hyperfunction, and then kind of working that gradually. So decontextualizing, say, how she's breathing instead of just do it in the context of singing. Try it in speech. Do you have the same motor patterns in speech as singing? And then decontextualize it further. How about with just breathing, no phonation? My approach also is, in terms of voice use and speech and singing and all of that, it's very rare that I feel that it's correlated with strength, but rather just coordination of the different subsystems. And so I kind of think that's why I prefer to say, I hear about these like exercises. I think a lot of times exercises get misconstrued as strengthening as opposed to re-coordination.
Right.
One thing that I drew kind of from my experience is in terms of that shortness of breath, I don't know if that was, a product of lung damage versus deconditioning, which we also know in terms of muscle atrophy, that literature says even up to 18 hours of disuse can lead to some degree of disuse atrophy. I was bedridden. I wasn't taking breaths for 6 weeks, Give a singer, no singing for a week. How much deconditioning, from this really elite level of muscle use are they experiencing too? So just, I think, really kind of resonating with everyone here is taking that slow recovery, but also pushing the limits a little bit while giving them permission to say, hey, this is a process.
I love this. Well, thank you guys. As we perhaps get ready to wrap up, this is a different platform for me, so I'm flying a little bit blind, not seeing questions. So if anyone has questions, get them in the YouTube link, and Alan will get them over to me. So I'll give just one more minute to see if any urgent questions come in. But I have to say, this has given me such confidence, and I really, I didn't know what kind of information I was going to learn tonight. But I think for me, the takeaway is that Dr. Young and Andrew, you've pointed out, there's nothing particularly new from the perspective of recovery from the singing. If somebody has worked with a singer with an injury or pathology. And I would say that if your singer is presenting, that for sure you need to make sure that they are evaluated by a proper laryngologist voice team and collaborate with an SVS if they do present with a lesion or a more serious pathology or injury. Correct, Andrew and Dr. Young, that we yield to that?
Yeah, I think this panel in particular, I think, highlights the importance of a multidisciplinary approach when we're dealing with something as complex as the voice, and especially with the singing voice. I mean, you can even hear just between Andrew and I that, have very kind of different practices and perspectives on how we manage these things. I mean, I've learned a ton listening to him tonight, and because that kind of therapy and that approach with people is not really what I do in the clinic. And that's why we so depend on our speech pathologists to help take care of that part, which is such a critical part of treating these particular injuries.
Mm-hmm. So we want our voice teachers to feel empowered to help their singers, but also to collaborate when necessary. Andrew, we do have one question. Introduce an activity that is incompatible with the hyperfunction. He says, I agree, it's challenging to instruct a don't. This strategy is helpful. Sorry, I'm thinking there wasn't a question there. It was more an affirmation of your idea. Yes. And yes, I think that is it. Any final words, Michael, from you as we wrap it up here?
Well, I mean, this has been very insightful for me as well, but it's great because, what we do as performers, working 8 shows a week, and then studying is really knowing your body and knowing what's off, and being able to articulate that. And so I'm fortunate enough to have worked with the same voice teacher for so long with Joan, that she knows me, but also I know when something's not right. And what I've found that I've had to untrain myself to do what should come naturally and not use the effort that I don't need. And that was the biggest part of my recovery, is going back to doing what should have been instinctive from the technique. Now it became, okay, Michael, stop doing that, right? And just allow yourself to do what you know how to do, and slowly building up my my strength to do that again. But conversations between voice teachers and students is such a personal relationship, and being able to be in conversation, especially post-COVID, because the idea is immediately to want to be where you were.
Yes.
And you just can't. You have to take your time.
Well, and for you, how wonderful, I think, having that relationship with a long-term relationship with a teacher who knows your instrument, you know, who knows the full potential. I think it would be harder to start with a teacher when and they don't know what your voice once was. That, you know, you can listen to recordings and that's helpful, but that was wonderful that you have that ongoing relationship. So thank you, everyone. I really, I especially Andrew and Michael and Cate for being willing to share your stories. You know, there's, as we've talked about for years, there's stigma around voice injuries, you know, and I'm sensing there may be a little perhaps stigma now as we come through COVID. And if you've had it and you were a singer, I hope not, but I think the more that we can have honest conversation and help each other, the better. So I really, from the bottom of my heart, thank you for sharing your story. And Dr. Young, your PowerPoint, that was so wonderful. Thank you. And your voice in all of this is so important, so that we keep speaking the truth in the field of voice. So thank you for that. Well, everyone, have a wonderful evening. Wear a mask, a very good fitting mask, please. Stay physically distanced, and please be well, and we'll see you again soon. Thank you, everyone.